but it's not just about you as an operator. Now, with these new guidelines, if you would apply them in your routine practice, about, at least in my own practice, about 50% of the cases, perhaps even 70%, would meet the criteria of complex PCI.
Yeah.
So if you're used to use 10 to 20% imaging on a daily basis because you think it adds a lot of time to your procedure, you're in trouble now, because you actually now have a guideline that tells you that you need, or actually you should strongly consider, if not need, to use intravascular imaging in patients presenting with complex lesions, which is 50% of your cases. So that would add a significant burden to you, but also to your team in a routine setting. So how do you handle that in Cologne? Did you talk about this with the team? Did you change something in the strategy? Did you optimize your workflow? Or what do you think is needed for people who are watching this webinar to really appreciate on how to practically handle this?
Yeah, I think this is one of the most important questions because if we discuss about intravascular imaging, everybody talks that he has it in his cath lab, but nobody uses it because there are a lot of restraints, which from my point of view are not really true. So what I do in my cath lab is that we have IVUS always available in the cath lab. So we don't put it in the room next door and somebody, if I call for IVUS, somebody has to bring it in. It's already there. And my team is already instructed, and what they do know automatically, if we start an intervention, and they already turn it on. So we have it available if we need it. And at the end, and this is what the operator has to think about, if you start thinking about using IVUS, then you can use it in the early phase of the procedure. So you just do one, maybe two angiograms, and then you switch to IVUS. So maybe it adds some time to the procedure by preparing the IVUS catheter and so on, which is only, to be honest, 1 or 2 minutes. But on the other hand, you can you spare some different angulations, 3 or 4. You spare contrast and so on. So at the end, I'm not pretty convinced that using IVUS in an optimized setting where everybody in this whole team knows what he has to do, that it really adds time to the whole procedure. But it may be the same at the end of the day. It takes the same time, but it adds safety. You really are able to use less of contrast during the intervention, and at the end, what we saw in the guidelines, the patient benefits in terms of a better prognosis. So I think it's important to discuss this with your team and to optimize your treatment flow, and then you will see that it doesn't take longer to do an IVUS guided intervention than to do it only angiographically guided. Or what is your opinion?
No, I totally agree. I think you provided a couple of very useful tips. I think putting the IVUS machine in the garage is certainly the first thing you should stop doing. You need to put the machine where it's needed, and that's in the cath lab and not in the garage. Second, I think it's very good if you don't have an integrated system, which I think should be the future. I don't think the future is in carts that you need to drive into the cath lab, but it's a different discussion. But you need to prepare it up front. If you know you're going to start a complex bifurcation case, a left main, a long lesion, do the setup of the imaging up front. Don't wait until you have done the pre-dilatation. I think that's a very good second suggestion to do. What we've learned in our lab is that is critical to embark the team. I mean, IVUS is a technology that you need to be able to move the buttons, as we say. So you need to be able to scroll through a pullback. You need to do measurements, and typically that's not what we do as an operator, sterile with sterile gloves, etc. But this is something that a technician or nurse needs to be able to do. And what we've learned, having used IVUS for many decades here in our institution, that the nurses and the techs actually really became, very confident with the use of imaging, and they actually started to like it because they suddenly get a role in how we do PCI, because they get the task to, by our guidance, do the measurements, help us to assess the calcium, to look for calcium fractures. Now even sometimes they recognize if the wire is behind the strut because they're with their faces on the screen, whereas we are 1, 2, 3 meters away or in the operating theater, whereas they are behind the screen. So that's really something that that is a continued effort you need to do with the team to make them enthusiastic. Review cases is another tip that I think I should be able to give you. It's not just a matter of doing or making a pullback. It's a matter of also reviewing the cases with the fellows and with the team in order to actually appreciate what you see. And I will guarantee offline you always see much more than you see online. And finally, I think it should be a team effort. And if you do it properly, we'll see that people start to like it. And then the fact that a procedure may take a couple of minutes longer because it's no more than that in a trained setting cannot be offset to the fact that evidence is now overwhelming showing that the use of IVUS, if used properly, can reduce all-cause mortality by 25%. I think there's no dispute, there should be no discussion as to whether the procedure time is just prolonged by 2 or 3 minutes. It's now suddenly turned into a procedure that actually decreases mortality with 25%. And that maybe even can be extended to the fact that PCR for stable angina, if you consider what we're doing in routine practice, PCR for stable angina, over 30% of patients still has angina after the PCI. I strongly believe that with the use of imaging, that can be improved. And that's a second argument, at least in my perspective, and the evidence still needs to emerge for that, that a proper PCI is obviously much better than a PCI just done quick and dirty in a quick, busy practice.